for joining on the third day on the for the Oral Awareness Month, which where ICanCaRe along with the Foundation for Head and Neck Oncology, Sterling Cancer Hospital, and Gujarat University, conducting this ICanCaRe second International Oral Cancer e-Conclave. So, a very warm welcome to everyone to this third day of scientific session.
Today's topic is local surgical procedures for oral cancer. And without wasting any time, I would like to invite Chairperson of the session, Dr. Manoj Johar. Dr. Manoj Johar is MCH Plastic Surgery from CMC Ludhiana, and he is head of the department, senior director of Max Super Specialty Hospital, Vaishali and Papaganj. And he is also director and promoter, Academy for International Career and Education. So, welcome, Dr. Manoj Johar. And for talk on local surgical procedures for oral cancer, I would like to invite Dr. Mudit Agarwal. Dr. Mudit Agarwal is senior consultant and head and neck surgical oncology in Rajiv Gandhi Cancer Institute, Delhi. And he is specialized in, I think, every head and neck surgery. And being radiation oncologist, it's my proud privilege to invite him for his talk and to hear from him. Welcome, Dr. Mudit.
Thank you, Dr. Rashi. And Dr. Manoj Johar, hello, how are you?
Long time. How are you? Nice to meet you again on this platform.
Yeah. Yes, sir. So I will share my screen, sir. I think in this talk, I will require your input because it's about the reconstruction. It's a difficult topic. I am just giving forward what I believe and what I do. I might be right, I might not be right. So all the senior fellows, Dr. Shinoy, Dr. Patnesh, they will have it because the practice which we do it also depends on that.
Yes.
So I will be talking about the local surgical procedures for oral cancer, when to consider reconstruction oral early lesions. So I will just briefly tell you about the factors which we need to consider while reconstructing oral cavity defect. So we are talking first of all of early defects. So defects means we have to see the location and what's the function of the organ and the size of the defect. And the flap, what we are going to use, should be reliable, functional, cosmetically acceptable, and of suitable size. And then one should match the recipient size, color, texture. And then after that, what we need to do is we have to see that minimal donor site mobility should be there. So defect, now we go to the subsite of oral cavity. So in buccal mucosa, usually I feel that if a small lesion is, or if you say 5 mm lesion is there or 6 mm lesion is there, you take a centimeter margin all around, you will need, most of the time you will require to need a reconstruction. What reconstruction? We'll go into it. So it needs a reconstruction. Otherwise, and most of our patients who are having already OSMF, they will require it because the defect what you create will be much larger than what you anticipate. For tongue lesions, for floor, mouth, alveolus, and palate and lip. So I'll be considering on that. So there are various loco-regional options present for T1, T2 lesions. One is submental flap, which is being very commonly used, but only thing we have to take care that it should be N0 patients. And if we suspect any node during surgery or during that, we need to abandon this procedure. Other flaps which can use are oncologically safe is infrared flap, which is based on superior thyroid artery, FAM flap, facial artery, muscular flap, supraclavicular flap, which is based on the supraclavicular branch of transverse cervical artery, and other flaps which we have ourselves devised is modified submental pedestal adipomyofascial flap, and the workhorse which we know of is a PMC flap. So other what local regional options can be there for palatal defects is a temporalis flap, which is based on the maxillary artery, deep branch of maxillary artery, and temporal palatal flap, which is based on superficial temporal artery. Nasal flap, it could be based on the labial artery of the facial artery, the labial branch of the facial artery, or it could be a random one also. Other flap which we have used is modified lateral trapezius flap, which is based on transverse cervical vessels. And rarely we have used buccal pad of fat, but can be used in conjunction with the flaps. Deltopectoral flap, usually in early lesions, you will not use it. Skin grafting, people use it, but I don't prefer it. Operator can be one of the options if we are doing an alveolar defect, and primary closure can be done. So other option which you can use is a free flap, where Dr. Johar mostly does it. And so now coming to answer and classification, how they did it. If you see the type 1 glossectomy means you have removed the mucosa. You can see in this figure mucosa and some of the interesting muscles. You can just leave it raw or you can just close it primarily. Now coming to type 2 defects of glossectomy, when you are removing the mucosa as well as intrinsic muscles, but you are not crossing. So these defects, you can leave it raw or partially close them. The type 3 defects which are there where you are reaching up to the midline and you're removing the extrinsic muscle as well, or you're crossing midline, then these needs to be reconstructed. The options which we have, as I just enumerated, the infrared muscle flap can be used, or infrared with skin you can use, PAM flap, modified SPAF flap, infrared flap, supraclavicular, modified lateral trapezius, and definitely microvascular free flaps are always there. But I will be sticking myself to the local region because in private practice, cost becomes a really problem. But talking science, it might not fit there. But in practical, if you see the most of the work, 60% of the work would be local regional, and 40% we would be doing a free flaps. So now coming to that, if for tongue, for T1, T2 lesion, if you feel the defect size, if the tongue volume is around 70% remaining, less than 30% of it is remained, then in posterior lateral border of tongue, then you can leave it raw, you can primarily close it, and one thing one should take care of it is avoid tip rotation. Middle, third lateral border of tongue, same principle is this, please don't, when you're doing a prime closure, don't avoid the tip rotation. And resection, when it's involved with the tip, or if you are resecting the tip, then that needs reconstruction. So various forms of flaps we can use it. So one of the examples I will show you is a small lesion, T1 lesion on the lateral border of tongue. So you take a 1 centimeter margin all around. This is the defect. So if you try to primarily close it, the tongue will get rotated fully. So what you do is just partially close it and leave the tongue raw. So the danger of that, you might feel that you might have a secondary hemorrhage because of that. So routinely, as you learn from the TORS, that lingual artery, we almost always ligate in a partial glossectomy where we think that we are leaving it raw. So these things will prevent any devastating hemorrhage which can occur in post-op time. So one of the patient whom we had done a partial resection and a primary closure. So infrared flap for the tongue defects. So this is based on the superior thyroid artery. You can take it from the neck here, and depending on the defect, you can take the amount of skin. So the width is a problem here. Width you can take maximum what you can pinch is a 4 centimeter, but you can extend it also. We have done a large infrared flap also. You can extend it also, but because we are talking about small defect, you can use this flap, and it's based on superior thyroid. No oncological compromise here, and you can use this flap for reconstruction. So this is one of our patient whom we did an infrared flap. You can see the tongue mobility.
बोलने में कोई परेशानी बोलने में अभी बोल रहा हूँ ठीक ठीक
So we had take a larger flap. Around width of this flap was around 4.5 centimeter, but we could achieve primary closure of the neck. Otherwise, we would have used a adjacent flap for reconstruction. So other flap which I was talking about is modified SPAF flap. This is basically a submental flap, but for males, what happens that because of hair growth, you can't use this flap, because that will cause, because most early cases, they will not require adjuvant radiation, and hair will be definitely a problem. So what we thought of it, why not go for technique like this? So you can use it for small, medium-sized defect. You will not require any deepthalization or laser epilation when we do this procedure. So we can use it in combination. We published this in our European archives. So just example of, so this is a tongue and floor mouth defect. So what we do is it's a N0 lesion, as I told, the indications are same. So we raise a supraplatysmal flap here of the skin. So, and the platysma is taken along with, then we raise a submental flap based on the submental branch of the facial artery. And then we take along with it anteropercular digastric and the myaloid muscle to give the bulk of it. So in that, you can rotate this flap through the floor of mouth and just reconstruct that defect. So this flap can be used for many other defects also. So supraclavicular flap is one of the flaps which we use it. And Dr. Shah also have a large series of using supraclavicular flap from Kidwai. So this is a little bit of like type 3 defect is there. So what you do is you reconstruct, you can see that it is based on the supraclavicular branch of the transverse cervical artery. So you can tunnel it through the floor mouth and use it. And the other problem with this flap is it will be like a band. So after a few months, you can divide this. So patient will have a good outcome. So other flap which we have used is, which we publish is modified lateral trapezius flap for tongue defects. So this is similar to supraclavicular flap, but it is based not on supraclavicular artery, it is based on the transverse cervical vessels only. And you have to cut, I landed on the trapezius muscle, where the transverse cervical, your spinal artery enters into the trapezius muscle. So this flap, you can use it. So this also gives us a good reconstruction for tongue as well as for floor mouth reconstruction. So other flap which are people from South, Dr. Joseph uses, is a FAM flap. This flap will not give you bulk majorly, but it will give a good cover. But one has to be cautious because our patients mostly are tobacco chewers, will be having some mucous fibrosis. So it's not ideal flap for these patients. Otherwise, it is a good flap. So now coming to partial orosectomy defect with floor mouth defect is there. Then if posteriorly located, we have to see whether orocervical communication is there or not. If orocervical communication is there, then we need to reconstruct these flap, this area. And if we find no orocervical communication, but we are very not sure, especially in glossotonsillar area posteriorly where it's very thin, that then we might have to augment by using an anterior belly of sternomastoid or a submural gland itself if you have spared them. Or mid anterior defect we usually used to need to reconstruct. So for buttressing, we have used a omohyoid flap. If you are feeling that if it's because if omohyoid is bulky, you can use this muscle, or otherwise you can use an anterior belly of sternomastoid flap for reconstructing. Dr. Alok Thakur has published it for TORS patients. So this is one of our patient whom we had a marginal mandibulectomy and a floor mouth resection, and infrared flap has been reconstructed. So what other thing we are doing it that because that muscle only flap of the infrahead cannot be taken. We take a platysma, we leave the skin there, and this we preserve the ansa cervicalis, and this all the strap muscles based on superior thyroid vessels can be brought into the floor mouth very easily and can be used to contour the tongue defect. So you can use a supraclavicular flap for the floor mouth defect as well. You can see it here. So now coming to defect like tongue, floor, mouth, and we have done a marginal mandibulectomy. So we need to cover the bone. So for these, reconstruction is required. So one of the patient where we have done a submental platysma flap without skin. We have done this marginal mandibulectomy, floor mouth excision, bilateral neck we have done, and this flap is raised and this is put here. You can see it, and on follow-up, patient didn't go for any radiation therapy. It was early lesion, and this is the follow-up, and no scar you can see virtually. So this is a good flap one can use in certain indications. So buccal mucosa defect, as I told you, in posterior small defects, you can use a buccal pad of fat, but it induces fibrosis, so it's not a great choice. But other flaps which I mentioned can be used for buccal mucosa. And buccal mucosa with RMT, definitely we need to reconstruct them. And if you have done it with upper areolectomy as well, where there is a breach in maxillary floor, then we need to reconstruct we need to use a flap which has a good reach. So pectoralis major myoclonus flap can also be one of the options in these patients. So in this one of the patients whom we had done a marginal mandibulectomy, you can see a T1, T2 bordering lesion, marginal mandibulectomy has been done, and we have not breached upper areolus has not been breached. So we have used a submental platysma flap. So he is just on follow-up since 3-4 years. But we have to advise that they should go for the use mouth devices for mouth opening exercises needs to be done for these patients. So similar SMAF flap for buccal mucosa, early lesion on follow-up, that's it. Another patient we have undergone buccal mucosa resection plus marginal mandibulectomy. So the thing is, if you use a typical submental flap and you don't give radiation to these patients, then definitely it will be a problem. Here both will be there. So we had done a traditional submental flap, but because the patient got radiation, so we got away with this problem. Otherwise, it's a terrible problem. So for typical buccal mucosa defect, this is otherwise would have required a RAF. So what if we did was a lateral trapezius flap based on transverse cervical vessels. So you can see here, it's and the skin which you are seeing is a deepthalized skin we have put as a graft on this side. We have not harvested any skin from there. So this article we published in European archives as well, and we have used for posterior wall defects also, tongue defects also we have used it. So we can use combination of these locations. Like if you see a defect which is there here in the buccal mucosa, you've done a marginal anatomy, and you have a defect in the upper alveolus as well as here in the in the anterior tonsillar, you reaching up to it. And then after that, you can reconstruct this. We have done a transverse oriented infrared flap we have used along with submental platysmal flap. And you can see posteriorly I put a submental flap because reach of this flap is very good as compared to this infrared flap. So it is used for buccal mucosa, and posteriorly we have placed this. So now for buccal mucosa defect, typical T1, T2 lesion, no radiation required. So supraclavian flap has been used. So we can use it for lip and buccal mucosa defect combination. Supraclavian flap has been used. You can turn it and you can use it. So now another patient of buccal mucosa plus lip. So you just resect this, and this was a defect with marginal mandibulectomy we had done. So what we have used is the supraclavian flap for inner lining, and outer cover what we used was a transverse, only the skin with platysma of the cervical lesion wherever you raise it, and you just approximate on the outer area. So you can use the combination of flaps. So another GT circus lesion, we had done a marginal mandibulectomy via local excision of the buccal mucosa, and we reconstructed the buccal mucosa and tonsillar area with this supraclavian flap, and bone was covered with the submental platysmal flap. So these are the post-op outcomes. So another patient of buccal mucosa with angle of mouth, and we resected the lip. In fact, you can see it here. And we use a nasolabial for outer cover and the lip reconstruction, and inside we use submental platysmal flap. So another which I'm not using it now sparingly, we are using it. The platysma with skin, you can use it based on extrajugular and branch of facial artery. We need to preserve it, and you can use it for reconstruction of a small buccal mucosa defect. So this is a tongue flap. I don't prefer it. Only this was a very cardiologically high risk patient and a small lesion. So we use a tongue flap and for this patient. Otherwise, tongue flap we usually don't prefer. You can use for small RMT lesions. You can use a masseter flap as well. But problem is that response will be there. So patient needs to be advised that they need to do a good mouth opening exercise post-operatively. So palatal defects also require reconstruction if you have a bone defect. Otherwise, you can leave them raw, or you can use a buccal pad of fat also. So options for maxillary entry is where obturator, you can use an obturator, you can use nasal flap, palatal flap, temporis flap is commonly used, and you can use a temporal palatal facial flap as well. So we have used for this, you can see the defect there, upper less and maxilla, portion maxilla has been removed. You can use this submental platysmal flap for reconstruction of these defect as well. And for this patient, he had already operated outside. We resected the mucosa here, and the soft palate was resected. So we use this remaining mucosa based on greater palatine and covered the soft palate defect, and rest was granulating by itself. So palatal flaps can be used based on greater palatine. And lip defects less than 1/3, you can close it primarily, or you can do bilateral advancement. But if more than 1/3 or 2/3, we have other options: Aviza slender, claropanzic, nasolabial, submental flap, modified SPAF, supraclavicular. You can use various kind of flaps. So what we have used for this patient, I will tell you, that is it's a buccal mucosa defect, and the whole of the lip has gone. So we have used submental flap inside, and we have supplemented it with nasolabial flap. So this is another lesion, early lesion of the lip, but skin was not, because already operated somewhere, biopsy was done. So we removed the skin, and you can see we had used a submental flap only, and then we had put this flap. And inside we had put a skin graft over the muscle area. So buccal pad of fat can be used, small posterior defects, you can use it. So split thickness graft have been described, but we don't use it. But anti-floral mouth, they found that its quality of life is not good, and worse chewing in one of the articles by Larson. So to conclude, I will say, for early buccal mucosal defect will require a flap reconstruction. Primary closure can be attained if less than 30% of the volume tongue defect is there, or you can leave it raw. More than 30% will require reconstruction. If floral mouth breach is there or oral cervical communication there, we require a flap reconstruction, especially GT circus lesion. If we are doing a marginal mandibulectomy, we require a flap reconstruction. Otherwise, for palatal bone breach is there, then we will require a reconstruction, or obturator can be used. For lip defect, which are larger, will also require free flap reconstruction. Thank you. Thank you. Kush? Yeah.
Excellent. I think Dr. Mudit, you've done a fantastic job, covered the whole topic beautifully, given us so many options with exemplary examples, clinical cases, etc. You were always, I think, more of a plastic surgeon than an onco surgeon. And whatever short period we worked for, you did shape our thinking for flap reconstruction. So, yes, you're right that 60% of it can be done under with these local regional flaps. However, I think it depends on practice to practice, and the kind of cases that we see, we are normally seeing more and more secondary cases or little late cases and things like that. So in that, the options do get limited. So just a couple of points, rightly so, cost is a factor, and functional outcome today is probably the leading guideline for the objective of reconstruction. So it's not just about cover, it's not just about getting the wound to be closing. I think it's a functional outcome which is paramount. So in those contexts, there are multiple factors other than cost as well. You know that better than we do. There's paucity of tissue, there are other comorbidities.
So I think flap is we know that it is one of the, see, we bank on flap all the time. But sometimes it happens that we have, a patient is high risk or something is there, or in our private sector, cost becomes a factor. So we choose other options. So that's why how we developed over a period of time.
Correct.
How can we go for local regional? Because PMC cannot be answered for small defects.
Yes.
So you need to have flaps which are thinner, which can be used.
Correct.
But we have to see oncological safety of the procedure, what we are doing. So that we have to see into context, and then we have to plan for it.
So I guess if case selection is done judicially and one is adept with the different knowledge of different flaps, it's very regular, normal to be able to use these options. However, 2 pointers. Number one, we are seeing a lot of secondary and tertiary recurrences, and so the fact that local options have been used up or compromised your tissues locally do add to a little surgical challenge later on. That is on one side. On the other side, now there is a lot of development happening on perforator flaps. So, for example, there are multiple perforator flaps based on radial artery itself. So one doesn't have to take a complete radial artery forearm flap as we know it. Traditionally, you can start raising smaller or finer on minor branches, which are perforator flaps. And so it sort of gives you a little bit more choice in terms of volume of tissue, adaptability of tissue, going to a further region without compromising also. These two factors can be taken into consideration when reconstruction is being planned. But other than that, I think what you have presented is fantastic.
Thank you, sir.
My compliments.
Yeah, thank you, sir.
Yeah, thank you, Dr. Mudit and Dr. Manoj. Your talk was excellent and excellent discussion, sir.